Hello.
Hello, Dr. Pravin.
Hello. Hi, ma'am. How are you?
Good, good, good. Nice to see you.
Same here. Thank you.
5 मिनिटं थांबूया ना?
हो, चालेल.
Shall we start at 11:10?
I think so. You tell me. I don't know. I'm doing this for the first time. कधी येतात नॉर्मली काय असतं काही ग्रुपवर टाकायचं वगैरे का काय
Takla already.
टाकलंय ना
I put it on the group.
किती लोक असतात नॉर्मली
So then it's around 40, 50.
ओके मग ठीक आहे वी गॉट 11 नाउ ओके दॅट्स गुड नंबर
Hmm.
यू टेल मी तेव्हा आपण स्टार्ट करू
11:10 ला बघूया. तोपर्यंत बघूया किती जॉईन होते. Dr. Pravin, I think we will start.
Yeah.
Yeah.
Right.
Okay.
Yes.
So, good morning, everybody. Very nice Sunday morning to you all. Today we have Dr. Pravin Patil, a young dynamic rheumatologist from Pune, who after completing his graduation from Topiwala Nair Medical College, completed his MRCP from Royal College of Physicians, UK, and CCT in rheumatology from London. He's a founder and director of Pune Rheumatology Center and the founder and medical advisor for the Ankylosing Spondylitis Welfare Society. Today, we are going to have a first session on ankylosing spondylitis, and he's going to tell us about the basics, the pathophysiology of the same. Okay, over to you, Pravin.
Thank you. Thanks, ma'am. Thanks for the kind introduction. I would like to thank MRA for inviting me to deliver this talk. So let me share the screen. So are the slides visible?
Yes, very much.
And am I audible, right?
Right, yeah, perfect.
Great. Okay, so hello, the PGs, everyone. Feel free to interrupt me, ask questions. We'll try to keep it interactive as much as possible. And let's see if I can navigate this quickly enough. Okay. So we are going to discuss about ankylosing spondylitis, and we'll briefly talk about the clinical features and pathogenesis, and we'll try to cover as much as possible. So let's start with that. So take home message. This is usually my first slides when I'm teaching. So I would like all of you, I think, how many are there? I think 11 or 13. So all of you to take down take home messages, 3 take home messages. So I'm not going to give you the take home messages. I believe that it is the audience we should decide the take home messages. I don't know what you find interesting or something new. So we'll ask some of you at the end, what are your take-home messages? So before I begin, I want to sense that how much background you have. I think some of you are in first year, second year. Is that it's a mixed audience? Is that right?
Yes, it's a mixed audience.
Audience,
mainly
right?
The one second year of post-graduation.
Sorry, ma'am. Second.
Most of them in the second year of residency.
Most of them second year. Okay, so some of them may have joined recently. So I hope this slides will be interesting for every one of you. So just to get an idea, so the PGs, I would like your answer. You can unmute and tell me about this. So is it true or false? Patients with normal inflammatory markers cannot have SPA. Anyone? We will be here till next Sunday if we do like this. Make it fast. I will be asking a lot of questions.
False.
False. Okay, very good. So how many percentage of patients with SPA will have normal inflammatory markers? Anyone? Okay, we'll move to the next. A normal X-ray of SIJ excludes diagnosis of AS.
False.
Very good. Next one would be a patient who tests negative for HLA-B27 cannot have AS. So that's easy one, right?
False.
Correct. And AS is rare among female patients.
True.
True. Are you sure? Is everyone agree with this?
No, false it is.
False. Okay. So we'll talk more about all these things. Okay. So let's start with a case. Okay. So 36-year-old male, 3 years of back pain. Back pain is intermittent. Sometimes it's worse at night. Sometimes it's worse with heavy work. It has pain all over the back. So not just lower back, the pain is all over his back. You do the lab test, ESR, CRP is normal, HLA-B27 is positive. By PCR method, imaging, bone scan there was done by the treating doctor, and the report says he has bilateral sacroiliitis. What will you do? So I suggest don't type in the chat box. It's very easy, very difficult when you are presenting and how to go through the chat box. So just unmute and talk. I think all of you yourself.
NSAIDs, like, could be given a trial of NSAIDs.
Okay, so you think this patient has angst. Anyone else? See, this is a real life scenario, right? We read about this all mechanical back pain, inflammatory back pain, but our patients, particularly our Indian patient, I find them, they're really vague, really vague. So they never tell you. But if you ever work abroad, you talk to this British patient, they talk like as if they have read the textbook. They give very good history. But our patients sometimes can be very vague. And this is very common that they give features of both inflammatory back pain and the mechanical back pain. So, so everyone thinks this patient has angstpond. Anyone? So just say anyone who wants to say this patient does not have angstpond.
Oh wait, so the history is written after heavy work, so that doesn't go more in favor of
Both. He has
inflammatory.
pain at night, so pain at rest sometimes, and pain sometimes after work as well. So he has mixed features.
Yeah.
Very common in clinical practice to see mixed features, right?
Yes, sir.
So we are unsure. Okay, so let's move to the next one. So this is 20-year-old engineering student. These are real life scenarios, by the way. I'm telling you about all this patient. This patient, the earlier patient comes from Nashik to see me for last few years. And I'll tell you more about that in the end. So 20-year-old engineering student, low back pain for 3 months. He has some enthesial pains, some thoracic pain, and difficulty with the spinal movements. His rheumatoid factor is very impressive. 640 CCP is negative. HLA-B27 is negative. Inflammatory markers are high. He was seen by the local doctor. He was started on methotrexate, prednisolone, and hydroxychloroquine. What do you think? What will you do? Anyone? I'm telling you, make it fast. We'll be here till next Sunday.
We'll do the imaging, sir.
We'll do the imaging. Imaging of what?
Sacroiliac joint.
Perfect.
And
So you are thinking away from rheumatoid arthritis, right? Just because his rheumatoid factor is positive does not mean. So see, the doctor who saw him started to treat him as RA because rheumatoid factor was strongly positive. He has given methotrexate, prednisolone, things like that. But the story is very much like angstpond. So you shouldn't shy away from changing the diagnosis just because the test is showing something else. Anyway, next one. So 52-year-old female, sudden onset of severe back pain, bilateral buttock pain for 2 weeks. She says she remembers having somewhat similar episode in 2008. The X-rays of the spine were normal. So this is again real life scenario, recently seen this patient. And so ESR is 48, CRP is normal, HLA-B27 is negative. What will you do next?
Imaging.
Imaging, what imaging?
MRI of LS spine.
MRI of LS spine is normal. Anyone else? So don't afraid of having wrong answer. There is no right or wrong answer. I'm giving you very limited information here.
Students should participate fast.
arterial Doppler, sir, to rule out arterial cause. Means it is sudden onset.
Arterial Doppler to rule out what?
Then it should be persistent.
I didn't get what rule out what cause.
Sir, to rule out vascular cause.
No. So think away from that. So see buttock pain. What MRI scan will you do? Lumbar spine?
SI, LS, yeah, lumbar.
Sacroiliac joint.
Sacroiliac.
Very important. See, in clinical practice, we often see that patient has back pain involving the buttock pain and only lumbar spine is done and SIJ often get missed. So we did MRI scan of the sacroiliac joints. It is showing left sacroiliitis. What will you do? So again, think about the history.
NSAID.
Okay, you started NSAIDs, no relief. So see, look at the history. History is only 2 weeks of back pain. Okay, only 2 weeks of back pain. And the age is 52. Okay, So they have to look at the features that it is not fitting completely with SPA, right?
Yes, sir.
Right. So that's why we have to start thinking away from severe pain, sudden onset. These words are very important. Sudden onset, severe pain, short history. MRI is showing left sacroiliitis.
Infective cause.
Perfect. Okay. So you don't have to go through many things. Okay. So just by history, you should be able to decide which way we want to head. So this is a 52-year-old policeman. He has ankylosing spondylitis for many years, not on any treatment at present. His younger brother is my patient. That's why he landed up in my OPD. His HLA-B27 was positive, sacroiliitis on MRI scan in the past, has a pretty advanced disease. Now you can say almost burnt out, has some comorbidities. And now he's here that for last 3 months, he has been having some worsening of the pain. He has again mixed features, inflammatory and mechanical symptoms, both. ESR-CRP is normal. What will you do next? So you will examine him, right? You will say, where is the pain? So he's showing the pain in the lumbar area.
So since it is the burnt out disease, now he will not get benefit with the anti-inflammatory drugs. So now we should advise the surgery for him.
Surgery, what surgery?
Joint replacement.
Joint replacement. Where is the pain? In the lower back. Which joint will you replace in the lower back? No.
It's not in the peripheral joints, no, it's in the back.
What do you think the cause of back pain here? So I want you to start thinking. So all these patients have back pain, but is the back pain caused by SPA or something else? Just because he has ankylosing spondylitis as a known cause, they can have back pain due to something else, right? Now, so why a 52
Yes.
in all these years, why he should come to a rheumatologist now? Why you should start thinking why there is worsening of pain.
There can be fracture of the spinal vertebrae because the
Very,
patient should
very
be
good.
on steroid.
Perfect. So this is what exactly was the cause in this patient. Okay. So all I did is
Yes, sir.
X-ray. We don't normally request many X-rays. But we requested the X-ray of lumbar spine and that did show the fracture. So the fracture in ankylosing spondylitis is a different topic. Anyway, but just to be aware of, patient with AS can have back pain due to something else. I think there's a noise. That's gone. Okay. So clinical features define inflammatory back pain. So what are the features of inflammatory back pain?
Early morning pain, which lasts for around 30 minutes to 1 hour and improves with physical exercise.
Great. So pain, stiffness for more than 3 months. So 3 months is very important point here because some people can have back pain that resolves within 3 months and starts before age of 40, starts slowly, improves with exercise, no improvement or worse with rest, pain at night. And then another one is the alternating buttock pain. And then they go through the cycle of good and bad days. Anything you know specific about pain at night? What does this patient tell you?
Restless leg syndrome.
So he says that it's difficult even to move sideways when he's
So turning
sleeping.
in the bed is difficult, but anything else they tell you about pain?
It occurs in the second half of the night.
Perfect. Yes, very good. So it's usually in the second half of the night. So they go to bed, they sleep well, and then it wakes them up. Okay. So this is the classic site for the pain, the one shown in the red. So it is the buttock pain. So all these three words are very important. Pain is diffuse. Okay. Very diffuse. It's not localized pinpoint pain, not focal. Okay. And then non-radicular. How far does it go down? The pain in ankylosing spondylitis coming from sacroiliac joint. Oh, okay. So the question is, does it radiate? Hello, I hope you all are still
So
there,
it
right?
could if so till the upper thigh or something like buttocks and the upper thigh. But if it is compressing a nerve or something, then it might radiate further.
So in the context of ankylosing spondylitis, it will not go down beyond the knee joint. Okay. So it will go to the back of the thigh. It is unlikely it goes down beyond the knee joint. If it is going beyond the knee joint, you need to start thinking about something else. So that is the slip disc sciatica type of pain, which would go beyond that. So it's in the buttock area or back of the thigh. Okay, so this is very important to know. So these three words are very important. So it's a diffuse pain, not focal, and non-radicular. Radicular usually means it goes down to the foot, so it won't in the context of ankylosing spondylitis. And they go through this good and bad days are very important because some patients for months or years they go into remission. Now the next one. So this is the description. So this is, if you go through the history, this is the earlier description. This was a French worker who had very tough time going to the work. So he used to wake up every 2 hours throughout the night, exercise, and so that he's ready to go for work in the morning. So this is the type of pain they get at night, the type of stiffness they get at night. Okay. So inflammatory back pain, are you aware of the 3 criterias?
Yes, sir, more than 3 months of less than 40 years.
What's the name of the criteria? Which is the latest criteria and who has defined that criteria?
Callin's criteria.
Okay, very good. Another one after that. Are you aware of ASAS?
ASAS criteria.
Great. So that's the Callin's criteria in 1977. Okay. Then there's the 2006. This is Berlin criteria. And then this is 2010 or 2009. So that's ASAS criteria. So that is the latest one or most accepted one. So they are all describe more or less similar things. What's the difference between 1997 and 2010? What have we managed to come up with different in this many years?
So the 3 months point, the more than 3 months point is not seen in.
That is entry criteria. So that's why I have not mentioned that here. So that is entry criteria. So inflammatory back pain is applicable only to those patients who have symptoms for more than 3 months.
So pain at night is not mentioned in 1977.
Okay. Anything else you notice different? So morning stiffness. If you see morning stiffness is there in 1977, there in 2006, but not in 2010. Right? So why did they remove the morning stiffness? So you read about that. Okay. So that has changed. Go through that paper. So inflammatory back pain is not the exclusive property of ankylosing spondylitis or SPA. Okay, so 30% patient have they will fulfill all the definition of inflammatory back pain, and they may not have SPA at all. So they may have some different causes as well. So that's why we need more features. We should be able to differentiate between inflammatory and mechanical back pain. I'm sure you are all aware of this. I won't spend much time here. So assessment of back pain. See, if you see the general population, how many people will experience back pain at some point in their life? So almost 9 out of 10 people will experience some back pain in their life. Okay. If you go through the chronic back pain definition, which is more than 3 months, almost 20% of population will have chronic back pain. So patients having chronic back pain, the probability of having ankylosing spondylitis or SPA is around 5%. Okay. So if we see patients who have chronic back pain in the general population, the probability of them having SPA is around 5%. So now we want to improve this probability to 90%. Okay. Just by talking to them. And can we do that without doing a test? So if we add the criteria of inflammatory back pain to these patients who are having chronic back pain, the probability goes from 5% to 15%. Okay. So this is chronic back pain. The probability is 5% of having SPA. If we add inflammatory back pain, the probability goes to 15%. So say if you add heel pain to that, the probability is 35%. So that becomes 40%. Okay. And say the patient has uveitis, then it becomes 90%. So a patient of chronic back pain having inflammatory back pain, heel pain, and uveitis, the probability of them having SPA is 90%. So if you use this various combination, and this we have not done the HLA-B27 or MRI scan at all yet. Okay, so just by looking at the SPA features, you can find out whether the patient has possibility of SPA or not. So these are different algorithms you can go through. So these are SPA features. These ones are called SPA features. They have heel pain, peripheral arthritis, dactylitis, and all those things. Okay, so these are SPA specific features. How about there are no SPA features? This is we see commonly in our practice, right? A patient has back pain, nothing, no psoriasis, dactylitis, uveitis, nothing. All he has is back pain. So what will help? That's where the investigations help here. So inflammatory back pain, no SPA features, the probability is around 15% of him having the ankylosing spondylitis. So again, in inflammatory back pain, no SPA features, but if HLA-B27 is positive, the probability goes to 60%. And then if it is negative, then the probability goes down to less than 2%. And if MRI is positive, then 85%. And then that likewise it goes. If MRI is negative, then probably it again goes down. So in patient with isolated inflammatory back pain, no other features, that's where the investigation should help you. So of these two patients, who has AS? I like this GIF, that's why I put it there. Probably it doesn't fit, but
The one with the
The
stoop
first one.
posture.
sorry,
First one.
first one has AS.
Oh, yes, sir.
One with the stoop posture.
So in your opinion, of these two images, which patient has ankylosing spondylitis?
That's on the left side of the image.
The one who is straight?
Yes, sir.
Yes, yes. And the other one, he doesn't have AS, you think?
I think the first one is because of the stiffness, he is straight.
Okay. Anyone else want to contribute?
So I think the second one, the one with a bent posture.
Okay. Anyone else? So we need one more opinion, then we'll fix it.
Both can have it.
Perfect. Yes. So this is where I want you to learn about it. My problem with our textbook is they show you this type of pictures, only the second one, where this is classic AS. This is too obvious. Everyone knows that. Even while walking on the street, I can identify people with this posture, they may have AS. Not that I go and give them my visiting card, but I just identify it. There's no point, no greatness in diagnosing if patient has developed this. So the great part is you should be able to diagnose patient at this stage when this is normal erect posture. Okay, so because of the stiffness, they don't become erect, they bend down. This is the natural way of reacting to the stiffness. Okay, so so the first patient almost looking normal can have AS, and we should suspect at that stage, not at the stage when it has advanced. So let's talk about the clinical features, musculoskeletal features. We talked about inflammatory back pain. When there is arthritis of the hips and shoulder, it is considered part of the axial skeleton. So it is not part of the peripheral arthritis. How is the peripheral arthritis in SPA? What is the classical peripheral arthritis picture in SPA?
Dactylitis.
Okay, anything else? Which joints involved in the peripheral arthritis?
Asymmetrical lower limb.
Perfect. So it is asymmetric lower limb involvement. So they can have enthesopathy as well, plantar fasciitis, and various other ones as well. Okay. What is this? So forget about the skin color. Okay, it is just the probably.
Dactylitis, it shows like a generalized swelling of the digits. So dactylitis.
Correct. Yes, it is dactylitis. What is dactylitis pathologically?
It's the inflammation of the tendon and the joint lining, of the fascia.
Okay, so I want all of you to read about dactylitis. What is the pathology of dactylitis? Okay, so you know the synovitis is different, right? Then there is tenosynovitis, right? And then there is a enthesitis. Okay. So what is dactylitis? In RA, we talk all about the synovitis. Early RA can have tenosynovitis as well. But dactylitis is very different. It is very specific for SPA.
It is enthesitis.
Yeah. So read about that, and or you can send me a message or something like that. Okay. So how common is peripheral arthritis in patients with SPA or angstphon? How common is hip and shoulder involvement? How common is the eye involvement? What number of patients can have eye involvement in SPA, in ankylosing spondylitis? Roughly. So there is a rule of 30. Okay. So around 30% patient have uveitis. Hip involvement is a major poor prognostic factor because that leads to hip replacement and things like that. And around 30% will have peripheral arthritis, like involving the knee or ankle joint are classically involved. Asymmetric large joint involvement. If patient is having rib cage pain or pain on sneezing, what do you think? Why patients with angstphon get rib cage pain or pain on sneezing?
Because of stiffness, fusion of the costochondral.
Yes, you are correct.
Costochondritis.
Costochondritis. Okay. So it is basically costovertebral and costotransverse joints are involved. So when we do MRI scan, regular MRI scan, they don't report on this. So I have specifically asked our radiologists to look for these joints. So when we request MRI scan, we try to cover as many joints as possible. And from the limited, I think I have around 100 patients maybe. So around 20% patients have costovertebral and costotransverse joint involvement. So this is important one as well to be aware of. These joint involvement. Some patient may not have all the classical features at that point doing the MRI scan. So if patient has costovertebral and costotransverse joint, that can help you to make a diagnosis. Can you diagnose a young patient with chronic low back pain to have SPA if MRI does not show sacroiliitis? So MRI is normal. Patient has inflammatory back pain, and they may have other features. But is it possible at all? Or if there is no sacroiliitis, then we can say, no, you don't have ankylosing spondylitis. You go to, say, orthopedic surgeon or something. Okay, are you aware of the classification criteria? ASAS classification criteria for ankylosing spondylitis? Okay, so let's go to that. Okay, so this is the ASAS classification criteria. So this is the patient, young patient who has more than 3 months of back pain and his HLA-B27 is positive, or he has the SPA features like inflammatory back pain, uveitis. So you can still diagnose it. You can completely ignore this. So sacroiliitis is not the essential things if patient has other SPA features. So this is very important to aware of. So earlier we used to fixate the existence of angstphon only around possibility of having sacroiliitis, but since 2010, a lot of things have changed. So which extra-articular manifestation you should look for in patients with ankylosing spondylitis?
Dactylitis, enthesitis.
Relief with NSAIDs, enthesitis, family history, psoriasis.
Uveitis, inflammatory bowel disease.
Particular manifestation we are talking about. So uveitis, yes. Anything else? Which system get involved for that matter?
GIT also can get involved, like we can have correlation with IBD, like association.
So uveitis, inflammatory bowel disease, skin involvement, psoriasis, they can have osteoporosis, restrictive lung disease, heart involvement, kidney involvement. What sort of kidney involvement they get?
IgA nephropathy and amyloidosis.
Perfect. Yes. So they can have this type of involvement. Okay. And this is rare, but these days we don't see much of like heart involvement and things like that. So history taking is very important. See, as I told you earlier as well, I find our Indian patients very vague when they are giving history. I struggle a lot asking them questions. I don't know how you guys find it, but so most important thing is no leading question. Okay, when you're taking this history, you should not give any leading question. So you should start with की सगळ्यात जास्त त्रास कधी होतो तुम्हाला? सगळ्यात जास्त त्रास कशामुळे होतो? This type of question, or ask them to show की उभं राहून दाखवा कुठे दुखतंय. This is how you should be going forward, because we learn all these things in English and it's very difficult to get the correct sense from the patients. So what's odd here? Have you all seen this picture?
Yes.
This is very classic, right? Almost everywhere it is seen. They show it all around in all the articles, any talk. The talk is incomplete till they show you this. It is almost mandatory. Sarkari niyam hai, दाखवलंच पाहिजे. But what's odd here?
The last person, like 1973, he should have been more stood, but he seems to be, his poster seems to be better than 1972.
Very good. That's Faria, right?
Yes, sir.
That's very good. Very good observation, right? So this is what they have started, is they started to show until 1972 only, so that they reduce the confusion. Okay. So, but this is the complete picture. So what happened in 1973? Why this guy become erect? Compared to earlier, there was no biologics that time, right? There was no big discovery between 72 and 73 in terms of medicines.
Steroids.
Nope.
Joint replacement.
Hip replacement. Perfect. Okay. So he had hip replacement, and that's why he looks little more erect than what it was earlier. But unfortunately, this patient died later on. Anyway, so this is a very clinical spectrum. We try to divide this patient between axial SPA and then peripheral SPA. This is what we'd like to see, that people with only axial involvement and then only with peripheral SPA. There is criteria for diagnosing peripheral SPA. So patients who do not have any axial symptoms and only peripheral involvement. Then why do we still call spondyloarthritis? I don't know. Don't ask me that. This does not make any sense to me to call a patient who has peripheral involvement, mainly the large joints like that, and HLA-B27 positive, and still call them spondyloarthritis. Very confusing, right? If there is no spinal involvement, just call it peripheral arthritis. But anyway, so this is what the nomenclature is. But in clinical practice, there is a lot of overlap. Like say, patient with psoriatic arthritis, they can have spondyloarthritis as well. So psoriatic spondyloarthritis with peripheral arthritis, that type of picture we do see, unless there are subtle differences. So these are some shared features of SPA. So irrespective of whether you are psoriatic spondyloarthritis or related to IBD, these patients can have some similar type of features or the involvement. So what's the difference between ankylosing spondylitis and axial spondyloarthritis, or AxSpA? Are you aware of there is a difference?
Axial spondyloarthritis would involve more of central joints like spinal with the vertebral column, and I think axial that goes with it.
And AxSpA?
Ankylosing would be, I think it would include both, sir, like with features of ankylosing, as in the fusion of joints. It could be peripheral as well as central.
No, so AxSpA can be axial and peripheral as well, and AS can be axial and peripheral as well. Anyone else know about the difference?
Radiographic changes are seen in ankylosing spondylitis.
Perfect. That's Manogna. Is that correct? How do you pronounce your name?
Manogna, sir.
Manogna, yes, that's great, Manogna. This is very important. This has been the game changer in 2010 or something. We have started to use AxSpA, basically, this new term, and that has been the game changer. So there was no concept of early ankylosing spondylitis in the past. So since the use of this term, we have started to differentiate. So what ASAS has done is, it is AxSpA which gets divided into two things, which is ankylosing spondylitis, and there is another thing called non-radiographic AxSpA. So AxSpA is two subdivision. Okay, so radiographic AxSpA is AS and non-radiographic AxSpA. Okay, So when we are talking about ankylosing spondylitis, what we are trying to say is patient has a radiographic axpa. Okay. So this is important one to be aware of, and we should start, all of us start using axpa the term. And where a patient has definite evidence of radiographic sacroiliitis, then we should use ankylosing spondylitis. So this is the definition of AS and non-radiographic axpa. So AS is basically definitely there is sacroiliitis. You can diagnose a patient to have non-radiographic axpa even if MRI scan is negative. Okay, so MRI scan, so the sacroiliitis can be transient sometime. It need not to be permanent thing. So sometimes when you do scan, it can be normal as well. So what are the predictor factors? So if patient has non-radiographic, some of them develop into the non-radiographic, go to the radiographic. So there are some features like baseline syndesmophyte, high disease activity, basically smokers. So any difference between non-radiographic axpa and radiographic axpa? Are there any clinical differences? No. So both of them can be very similar, but non-radiographic axpa is seen more commonly in female patients. So are there,
रख लो ना आपको
189 ना
बेकार रहेगा लेकिन दूसरे
I think
चलने
you,
के लिए ऑफिस में
I think who is talking?
ये तो ये यहाँ बहुत सारे हैं एक ले जाओ
Sarvana?
सॉरी सर सॉरी
Right. So, so are there any sex differences? So any difference between the male and female patient with SPA? Are you aware of? So earlier when I asked some of you thought that AS is rare in females. So it is not rare. Okay. Now the recent study is showing it is as common as in men. However, it gets underdiagnosed. Nowadays, we have started to diagnose. Nowadays, we have started to realize that there are differences in clinical features presentation as well. Okay. So the patients, the female patients often have features of fibromyalgia along with some SPA features. And they can have depression, anxiety, and all other. So they tend to have less deformities compared to men who have more fusion and more deformities, but the disease burden is same. So because of the fibromyalgia, if you look at the BASDI-BASFI scores, they can be very high in female patients. So due to the accompanying features. So I believe a lot of patients with fibromyalgia, we should be actively looking for sacroiliitis or the HLA-B27 positivity. The enthesitis, the tender points could be basically SPA features. So do you know how long it takes? So we have 15 minutes. Do you know how long it takes from first symptom onset to observing the changes on the X-ray?
5 to 10 years.
Yeah. So it can take up to 9 years. So that's why we are moving away from the rigid definition of having sacroiliitis on X-ray. So the earlier criteria required that we should have sacroiliitis on X-ray. Then your criteria does not indicate that. So that's again for you non-radiographic stage. And then if you can see the years, it takes many years for them to progress to radiographic stage. Mind you, not all of them will progress. Some of them will remain non-radiographic throughout their life. So pathogenesis. So there are three things you should be aware of when it comes to the pathogenesis. So one is the genetic factors. Second one is the gut microbia. Sorry, this thing is gone wrong. So the genetics, the gut dysbiosis, and the mechanical stresses causing enthesitis. These are three things. So pathogenesis involves inflammation, bone marrow edema, then there is a repair process, and there is newborn formation. We'll talk about these three things in next few slides, that how it evolves in the context of Angstmond. So these are three main therapeutic targets: the COX, and then the COX enzyme, the TNF alpha, and then interleukin 17. So this is what happens when the process of syndesmophyte. So syndesmophyte develop here at the corners, vertebral corners. So what is this? What is happening here is the enthesitis. Okay. So this enthesitis, so that's where when we do the X-ray, it shows the erosion or the sclerosis, the shiny corner sign. And then the syndesmophyte will cause the bridging osteophytes or the syndesmophyte. And that is where the bamboo spine starts to occur. So when you do the MRI scan or the histology changes, we have observed that it goes through this process. So when there is inflammation, and at this stage, if you do the MRI scan, it will show what does MRI scan show? Inflammation, how does it show? In SPA, so it will show bone marrow edema. Okay, then it will show some erosions, bone destruction. So this is best seen on CT skirts. So many times when I request MRI scan, my radiologist will ask for some CT skirts as well. And then inflammation is there. So there's a repair mechanism. So how does it look like, or what is the lesion on MRI scan? The repair tissue. So one is bone marrow edema. Then there could be erosion. And then last one is the osteoproliferation, which is the syndesmophyte formation. So before that, there is a repair mechanism. So I showed you these three things you should be aware of: inflammation, repair, and new bone formation. So between inflammation and formation of syndesmophyte, there is another process is happening, which is drifting for SPA. So what is it? What is this stage is called on MRI scan? What these lesions are called? I will send you a toffee if you get the correct answer. What word I'm looking for? Are you aware of fat metaplasia?
Fatty metaplasia.
Great. Okay. So fat metaplasia is a newer term and very much of big interest among the SPA enthusiasts. So how pathogenesis of SPA is different from RA? So here erosions are happening, and in contrast, at the same time, new bone formation is going on. This is how it's different. In RA, it is mainly all about the erosions. There is no new bone formation, right? RA is all about synovitis, and SPA is mainly about enthesitis. So MRI can visualize in both inflammation. Inflammation is equal to bone marrow edema, repair process, which is fat metaplasia, and then there is a new bone formation, which is the syndesmophyte. There is a score for fat metaplasia on the MRI scan. So they have started counting it, and they are using it in follow-up. So you should look about this. So these are the cytokines TNF alpha 17 that activates the osteoclast, and then that leads to the repair process, and that finally leads to the new bone formation. And the interesting thing is this new bone formation or syndesmophyte occur at the place where there is a fat metaplasia. So the place where there was inflammation, bone marrow edema, then that develops into fat metaplasia, and that goes into the syndesmophyte formation. So we should target at the time of fat metaplasia. So the new bone formation does not occur in the vertebral body where the inflammation has destroyed the microarchitecture. So it occurs at the periosteum cartilage junction. So this is the diagram. This is synovitis showing in RA. You can see that there is a synovitis or the proliferation here. And in SPA, there is enthesitis there at the corner. And then the various enthesitis, you can see that. The enthesitis is usually little away from the joint. If you see, these are away from the joints. So true or false? This is the last few slides, okay? We'll finish in time. So patients with normal inflammatory markers cannot have SPA.
False.
False.
A normal X-ray of SIJ excludes diagnosis. Yes. A
False.
patient who tests negative for HLA-B27 cannot have AS.
False.
And AS is rare among females.
False.
Great.
False.
50% patients can have normal inflammatory markers in the context of SPA. Okay, so this is very important. But if ESR CRP is high, then it is a sign of poor prognostic factor. So patient with normal X-ray, we know that we should be doing MRI scan if you suspect patient has angstpon, if X-rays are normal. Okay, and MRI can detect the early changes. HLA-B27, I think this is you all must be aware of that. So let me ask you a question. If you take 100 patients, if you go on the street, check HLA-B27, you found 100 patients who are asymptomatic. How many of them will develop SPA?
70%.
normal population, HLA-B27 is positive, 100 patients are there. How many of them will develop SPA?
5.
Yes, it's written there, right? So less than
Yeah.
10%, so around 5% will develop. So this is very important. So any test should have good pre-test probability. So it is not a screening test. We cannot put HLA-B27 testing kit in the spine OPD of the orthopedic surgeon and check everyone. So women are as likely to have SPA as men, and we know that there are certain differences. That's why it gets undiagnosed in these patients. So case 1, 36-year-old male, 3 years of back pain, had the mixed features, intermittent pain. The labs were normal, but HLA-B27 was positive. Imaging showed bilateral sacroiliitis on bone scan. So what is the problem here? See, here what I'm trying to give you the message is that the history is not suggestive of SPA. So the pain is all over the back, not just in the lower back, right? He has diffuse pain, he has intermittent pain, so not very consistent. So here I start thinking away from SPA. So forget about all the test which is showing this is positive and that is what. What's the problem with bone scan? I think till almost 2005, we were using a lot of bone scan for sacroiliitis, but we stopped. We moved to MRI. Bone scan is too sensitive. So bone scan can be false positive. So for this patient, we did, so I knew this is not angstpond. I stopped all his medication. Just to prove this, I did the MRI scan of the sacroiliac joint, which was completely normal. And to cut the long story short, basically patient has fibromyalgia type tender spots, and he doesn't have SPA, but he still comes back. I'm seeing him last 7-8 years. Every 1 or 2 years, he goes to some rheumatologist or some orthopedic surgeon who sees the positive HLA-B27 and bone scan, and they tell him that, oh, you have angstpond. No, he doesn't. He has excellent range of movements for this many years. So anyway, just don't go by the reports. Look at the history. So about this engineering student, he has everything there, right? Up till this point, everything fits with SPA. Just because rheumatoid factor is very high doesn't mean that this is RA. Let the rheumatoid factor be there. He doesn't have any features of RA. So we should feel confident to tell him that this is SPA. You don't need methotrexate here. We need different line of treatment. Third patient, this is a female patient. She has sudden onset pain, severe pain. Though she tells you anyone can have pain in the past, right? Does not necessarily it is related to the current episode. So she may have had something else. So here, when we did the MRI scan, it showed unilateral sacroiliitis. I was suspecting septic arthritis. That's why I went ahead and did the scan, and then the biopsy showed that she had TB of the sacroiliac joint. This is the policeman. We talked about the fracture in SPA. You should read about the fracture in SPA. It is little different, the spinal. So it is the paradox. The bone is stiff. The bone density will show normal or even high than the normal population. Okay. So there's because of the new bone formation, but they still have osteoporosis. And when I asked this patient that, why did you come here? Why do you think there is a worsening of pain for last 3 months? How this pain is different than earlier? Then he volunteers that that he had a fall 3 months back, and then it may be related. This is what he thinks. So he did not correlate with that straight away. And then everything falls into place that it was related to the spinal fracture. So that's the end of it. I hope we have finished on time. So what are take-home messages? So let me see now how many of you are there till the end. Let's see. So 28. Okay. So who has not said any word till now? So I want them to volunteer and tell me their take-home messages. I don't want to pick any name. Volunteer, or then I will have to pick some names. Okay, should I pick the names? Okay, Anjali.
Yes, sir. So we should go with the history first, not the investigations.
Okay, so Anjali's message is we should look at the history, not go by investigation. Supriya. Harsh. Nivedita. Let me see. Do we have our Pune students? I think all are sleeping. They went somewhere just by logging in, just to keep Dr. Kavita Krishna happy. Lakshmi. Okay, anyone? Any other message?
Sir, even if the markers are negative, we should still think of spondyloarthritis.
Okay, good. So if inflammatory markers are negative, so almost 50% will be negative. The last one, only one, third message, and then we are done.
So females also can develop.
So this is one thing, if you remember from today, that suspect SPA even in female patients. So that was the traditional teaching that females don't have. Just the other day, I saw a female patient, a top shot orthopedic surgeon in Pune, told her confidently 5 years back that this is the disease of male patients. You cannot have SPA, go away. And that's the that's what led to the delay in diagnosis. So anyway, so that's the end of it. Any questions? Anything, ma'am? I'm handing over to you.
Pravin, can I just add one thing?
Yes.
Dr. Oak here.
Hi, ma'am.
Yes, ma'am, please go ahead.
Yeah, very nice lecture, Pravin. I enjoyed it.
Thank you.
So basically, one other thing which I feel we should always see is a neurological deficit in every backache. If there is a neurological deficit, then of course it's a mechanical backache. Like ask the history of tingling, numbness, or weakness of the great toe. And the other thing, what people don't do is examination of sacroiliac joint. So that part I think somebody will have to cover in the lecture, so that you will be able to understand how the sacroiliac is examined, so that you know that the pain is generated from sacroiliac.
Yes, correct, ma'am. Very valid point. I missed out that in my talk. So that is a very important one. Thanks for adding.
Thank you, ma'am, for your input. Very nice. And Pravin, it was really nice. It's like going back to residency. Thoroughly enjoyed it.
Thank you.
I wish more and more students join and take advantage. We all take out so much time on a Sunday, and we
And I
want to
think the
give.
students should participate actively. They should do it. Yeah.
They
Yeah,
have
that's
to
why I
do
think we
it.
should try to keep it more interactive. This is your chance, students. Or you can hide your name if you have problems in showing your name. Just put something random, Michael Jackson or something. And you can talk. No one is here. It's the beauty of having virtual talk, right? I feel more participation will be there because of the virtual talk.
I think the way Dr. Pravin has put it up, whenever you see a patient of backache, I think he's going to come in front of your eyes and tell you, oh, this is not back, this is spondyloarthropathy, mechanical pain. So please take, I would request all, even teachers to please tell your students to join in. It is for them. We are not getting any benefit from this other than the pleasure of teaching. So all rheumatologists are hardcore teachers, and we want you all to have a hang of the subject so nicely that it's for actually in the interest of the patient, so that you don't miss diagnosis. Because these diseases are all having long-term irreversible damage. Treated in time, the patients can have quality of life can change to a great extent. So please, students, please join and take this lecture seriously. Thank you, Dr. Pravin. It was very nice. Thoroughly enjoyed it.
Thank you.
Yeah, thank you, students. Yeah. Thanks to all the
Pravin,
faculty.
thank you, Pravin. Thank you, Varsha.
Thank you, ma'am. Thank you, ma'am, for joining. I think we call it off.